Hello, and welcome to Week 5 of the Introduction 2020 Faculty Perspective Series. We've designed these programs to allow you to see the tremendous depth and breadth of academic research interests amongst our faculty, and for you to preview many of the exciting things that you can study here at the University of Oregon. Over the course of the summer, we are presenting faculty perspectives in 5 separate tracks. As a reminder to you students who are watching live, be sure you complete your reflection on this program after we're done by visiting community.uoregon.edu. Additionally, you can earn a class credit by watching and reflecting on 2 full tracks, plus 4 additional faculty perspectives, and completing the capstone reflection assignment on the community.uoregon.edu site. The last 15 minutes of this session will be dedicated to answering your questions live on camera. In Zoom, please use the Q&A feature at the bottom of your Zoom screen to ask our presenter your questions. International Studies Professor Kristin Yarris explores the social factors that are driving disparities in the COVID-19 infection rates in the United States during this week's COVID-19 track. Welcome, Dr. Yarris.
Thank you. Thank you, Cora, and thank you so much for having me this morning. So I was asked to design a key question around which to organize my talk with you today. And I thought that the key question would be, what social factors underlie the disparities in coronavirus infection that we see in the United States across racial and ethnic groups? So I'm excited to talk with you about my reflections in response to that question this morning. As Cora said, I'm an associate professor in the Department of Global Studies. We have a new name. I also direct the Global Health program here on campus. We have an undergraduate minor in global health, which is deeply interdisciplinary, drawing from courses in the social sciences, humanities, and natural sciences. And at the end of my presentation, I'll share our website with you. I welcome all of you to consider having a global health minor as part of your academic experience while at the University of Oregon. And in my talk today, you'll see that I draw equally on social sciences like social epidemiology, on natural sciences like human physiology, and on the history of infectious disease and bioethics, among other humanistic fields, to understand racial and ethnic disparities in coronavirus infection. This interdisciplinary approach is key to our global health program, so I think my talk today will give you a taste of the kinds of things that you might learn were you to join the global health minor. So coronavirus has taken a terrible toll in the United States. As of just the other day, and every day case counts are rising, as we know, so from one day to the next, the numbers become dated. But we have approximately 4.8 million cases in the United States, over 158,000 deaths at last count. This makes the U.S. one, if not the most impacted country in the world by the coronavirus pandemic. The U.S. has more cases and more deaths than any other country. And to be frank, this is not a statistic we ought to be proud of. As one of the wealthiest countries in the world, we could and should have done better. And towards the end of my presentation, I'm going to reflect some on what types of policy and public health programs might help us get out of this pandemic. In population health and public health, we talk about preventable death. Preventable death is a notion that death rates, rates of disease, morbidity, and mortality in the population weigh more heavily on some population subgroups than others. And when we see disease and death rates disproportionately impacting certain population subgroups, that is, their rates of disease and death or morbidity and mortality higher than population averages, we know that those deaths are preventable. So what we see with coronavirus infection in the United States and COVID-related deaths in the United States are preventable deaths. And for me, as someone with a public health background and someone who runs the global health program at the University of Oregon, it becomes a moral question for me about how we can respond better with public health policy so that fewer people die. Alongside the health impacts, about which we are still learning since this is a novel disease, and the long-term impacts of COVID-19 infection among different age groups are still unknown. There are also less visible tolls in terms of mental, psychological, and emotional health. Many scholars around the world are talking about dual pandemics. The mental health impacts of the pandemic will be long-term, and they include social isolation, depression, anxiety, and uncertainty that also accompany the high rates of unemployment. So there is a lot to be concerned about at this time, and there is much blame to be laid at the hands of the federal government in the United States for a failure of leadership, coordination, and health governance during the pandemic. But also the underlying social, economic, and health disparities that are producing the current disparities in coronavirus infection and COVID death rates that we're witnessing in the U.S. are long-standing and have historic and structural roots. The pandemic is, in fact, exposing underlying social inequities in the United States that are structurally reproduced through social institutions such as education, healthcare, and housing. One other thing I will mention is that we have another dual pandemic of misinformation in the U.S. So health communication has become critically important. The way people get their public health information has become critically important. And while I don't have time to talk about it now, I've gotten involved in a research project with our local county Department of Public Health this summer, examining the ways Latinx communities are obtaining their information related to coronavirus in order to reach them more effectively. So there are ongoing research projects by myself and colleagues across this campus that undergraduates can get involved with to help address some of these systemic problems. Another specific challenge that is played out globally and in the U.S. relates to data collection, that is, monitoring and surveillance of the disease. So globally, it is the World Health Organization that is responsible for scaling up and sharing epidemiological information on disease incidence and prevalence rates. However, the U.S.'s current threats to WHO and threats to defund the WHO aren't helping matters, as the WHO needs its full resources in order to respond to this pandemic across the globe and to respond to future health challenges. In the U.S., early in the pandemic, public health officials and researchers noted that data on coronavirus infection, that is, case rates and death rates, was unevenly tracking racial and ethnic disparities. So how does this data get collected? The mechanism for collecting racial and ethnic data in disparities in infection rates happens at the local level. It happens at hospitals, and it happens by local county departments or municipal departments of public health. From there, data gets transferred up to the state level and then to the national level, for instance, to the Centers for Disease Control and Prevention, or CDC. This is standard public health data surveillance and monitoring, and it is key, that is, data collection is key to being able to track the impact of this pandemic and the disproportionate impact of this pandemic on specific population subgroups. However, during the last 6 months, data collection has been incredibly uneven across the United States. This has led researchers, public health advocates, and journalists, such as those from the New York Times, to demand racial and ethnic data be collected and disseminated for wide public use. So the New York Times produced a Freedom of Information Act request on the CDC and forced the CDC in June of this year to release racial and ethnic data. The reason I'm emphasizing this is I'm about to show you graphs, data, tracking the disproportionate toll of coronavirus and COVID on U.S. racial and ethnic subgroups. I would not have access to this data if it weren't for these advocates and journalists pressing the government to release the data. So while imperfect, this data is essential for us in public health advocacy, for policymakers, and for programmers in public health to be able to respond proportionately to the impact that the coronavirus pandemic is having on specific population subgroups. So data collection is key, and I'm going to now show you some data coming from the sources that I will have listed on these slides. So what do we know from available data about racial and ethnic disparities in coronavirus infection and COVID-19 death in the United States? So all of the data here comes from the COVID tracking race project. You can see the website there. It's pretty exciting, and you can go in and interact with this data and map according to the state that you're interested in. The website also shows where holes in the data exist and is asking the public to weigh in to participate in advocating for better data collection and dissemination. But generally speaking, we see that the coronavirus pandemic in the U.S. is disproportionately impacting communities of color, particularly Black and Brown communities. So, for instance, while Latinx people comprise 34% of COVID cases nationwide, they are only 18% of the national population. In states like Wisconsin, the disparities are even greater, with Latinx comprising 7% of the population of that state, but 33% of cases. In some parts of that same state of Wisconsin, Black Americans are 25% or a quarter of the population, but over 80% of COVID-related deaths. Nationwide, Black Americans are dying at 2.5 times the rate of white Americans. Over 31,000 Black lives have been lost to COVID-19. Where race is known because there are missing data still, Black Americans account for about 22% of COVID-related deaths nationwide. So Native Americans are also suffering disproportionately to coronavirus infection. In the Navajo Nation, located in the state of Arizona, infection rates are higher than in many other U.S. states. And while Asian Americans haven't seen the same disparities in coronavirus infection and COVID death, the xenophobic race baiting, and stigma discrimination against Asian Americans that we've seen, unfortunately, since the start of this pandemic in the United States is cause for concern and probably the topic for another talk altogether. So disparities across these racial and ethnic disparities in coronavirus case infection rates and in COVID death rates exist across all population age groups, but they are more pronounced for people over 60. And I'll talk a little bit about why that might be towards the end of the talk. Also, these disparities exist across all geographic regions, urban, suburban, and rural America. Furthermore, these disparities are not explained by income differences alone. So there is something particular about racial discrimination that is producing and structural racial inequalities in the United States that is producing these disparities in coronavirus infection and COVID deaths. So we'll look a little bit more at some data, and then I'll offer you some possible explanations for why we see these disparities. So another way to visualize this data is in racial inequalities in coronavirus infection rates. And like I said earlier, some of this data is coming from the New York Times, which demanded it be released by the CDC in June of this summer, and they're producing some innovative ways to visualize coronavirus data. You can see that on their website. So overall in the U.S., the white coronavirus infection rate is 23 per 10,000. That compares to a population average of 38 per 10,000. A Black American average of 62 per 10,000, and a Latinx average of 73 per 10,000. So as I mentioned earlier, for Black and Latinx Americans, you see that coronavirus infection rates are disproportionate to population averages. So those are preventable. We would call that in public health preventable infection. So that's infection rates. What about death rates due to COVID-19? We similarly see patterns of racial and ethnic disparities. Deaths for Black or African Americans are about 77 per 100,000. For Latinx Americans, about 42 per 100,000. For Alaska Native and American Indian Americans, 41 per 100,000, etc. So it's not just infection rates that are disproportionate, but also COVID death rates. This is another way of visualizing these population data. These two lines show Black and Latinx coronavirus case rates in the United States, and they're only through about mid-May, but it shows you that both Latinx and Black Americans have infection rates about 3 times the rate of white Americans. So I just wanted to put this slide in here because many public health professionals are talking right now about the importance of data visualization, of helping Americans understand the population-based impacts of coronavirus through data visualization. And I think this is a really exciting field. And like I said, some of the websites on my slides allow you to go in and manipulate the data and produce graphs, tables, and charts of your own, which is an exciting and interactive way to engage with this data. So these disproportionate impacts of coronavirus infection have also hit home in the state of Oregon, and I just thought I'd show you some data from the Oregon Health Authority. Oregon Latinx communities have been disproportionately impacted by coronavirus. You can see there that among Hispanic or Latinx Oregonians, while only 13% of the state population, there are about 44% of all overall coronavirus cases in the state. So how might we explain what possible mechanisms of explanation are public health researchers putting forward for these disproportionate rates of coronavirus and COVID-19 death in the United States? In public health, we talk a lot about multiple levels of influence on health. We can think of explanations for health inequalities in the U.S. and around the world as existing on multiple levels of influence on health. Thinking in this way from individual to community to institutional, organizational, and policy level, and across all of those levels, having interactive impacts on health outcomes, is called a social or ecological approach to health. And so in my classes in global health, I talk a lot about the socio-ecological model, and we practice looking at health disparities in everything from life expectancy to chronic disease rates such as heart disease or cancer to infectious diseases such as coronavirus. We practice mapping the analytical levels of influence on health and then brainstorming ways, therefore, to influence, promote health, targeting these multiple levels of influences. This is some of the key work that we do, so the key skills that you would build as a global health minor student. So doing a multi-level needs diagnostic enables us to think about the production of health at multiple levels of influence. So we might think of coronavirus disparate infection rates as partly due to individual level risk factors, that is, behavioral level risks. What are we talking about here? Things like washing our hands, things like congregating in groups or not congregating in groups, things like keeping safe social distance or not, things like engaging in indoor crowded activities without masks or not. These might all be individual level produce risk. Sharing food, sharing utensils, things that we could target health promotion interventions at the individual level, encouraging people to maintain social distance, wear face coverings, not share food and utensils, etc. Those things certainly are playing a role, but less of an important role in producing the disparate rates of coronavirus infection that we see by racial and ethnic groups in the United States as some of the more structural, social, and policy level factors that I will talk about in a moment. Another set of explanations for health disparities is describing or explaining racial and ethnic disparities in coronavirus and COVID as a product of underlying pre-existing conditions. So for instance, saying things like Latinx or Black Americans have had higher rates of heart disease or respiratory conditions preceding the pandemic, therefore leaving them more vulnerable to coronavirus infection and COVID-19 related death. In part, scientists are now being able to show that pre-existing chronic conditions, underlying conditions like those I just mentioned, are contributing to health disparities in COVID-19 deaths, but not explaining fully the disparities that I showed you on the previous slides. So I want to focus more here with you in the next couple slides on social and structural explanations for health disparities and on the types of policy solutions that we might put forward to minimize some of these social and structural risk factors, if you will. So some of the risk factors producing racial and ethnic disparities in health outcomes during this pandemic are occupational. They're workplace-related risks having to do with the fact that Black and Brown Americans are on the front lines as social service workers, as health workers, as restaurant workers, as retail service workers, as workers in the logistic industry, shipping, delivery workers, and as healthcare workers. And as such, they have not been able to take time off. They've been pushed to showing up for work without paid sick leave and continuing to work through the pandemic. And their work in and of itself is exposing them to greater risk for coronavirus infection. And then we also have policy factors, such as the fact that in the United States, one of only a few wealthy nations in the world that does not have paid sick leave. So historically, people have had to show up when sick. That hasn't changed during the current pandemic, and that leads to greater spread of disease because people have to work because they can't afford to stay home. So the pandemic is putting pressure, in addition, on public health systems in the United States that have been chronically underfunded, also as a result of public health policies. So the Center for Disease Control and Prevention has been defunded over the past decades, leading to a shortage of resources for things like public health laboratories that are key to turning around rapid test results so that we can trace coronavirus cases and contain the spread of the disease. These are the types of upstream social and policy-related factors that I want to focus more on that are producing the current disproportionate impact of coronavirus infection and COVID death on Black and Brown Americans. Excuse me. So people of color are America's essential and frontline workers. Excuse me. I'm not used to talking this much. Haven't lectured in a while. People of color are on the front lines in food processing, agriculture, logistics, healthcare, home care, and domestic service. And in these industries, they have very little occupational or workplace protections. These vulnerabilities keep Americans of color going to work even if they're sick, and they expose them disparately to coronavirus infection. We also know that the Occupational Health and Safety Administration of the U.S. government has been ill-equipped and has not responded proportionately to the amount of workplace complaints that it has received during the pandemic. So OSHA, the Occupational Health and Safety Administration of the United States government, has received over 6,500 workplace-related complaints from Americans working in food production, meat packing, fish processing, agriculture, healthcare. Over 6,500 complaints during the pandemic, but has only issued one employer-based citation. So there is just simply inadequate regulation of and enforcement of workplace safety and protections for American workers. And we see that across the country and in states like Oregon, workplace outbreaks are in fact contributing to the ongoing high rates of coronavirus infection that we're seeing during this summer. So for African Americans, in addition, Black Americans are more likely to work in service sector jobs than white Americans. In those jobs, they face low wages and few workplace protections. Other inequalities, social inequalities facing Black Americans that make them more vulnerable to coronavirus infection include less likely to own cars, more likely to use public transportation, low home ownership rates. In fact, Black Americans have the lowest home ownership rates of any racial and ethnic subgroup in this country. That means it's very difficult to social distance at home or during stay-at-home orders or sheltering-in-place orders. Black Americans are facing more overcrowded housing conditions. And Black Americans face residential segregation as a result of long-standing historical, social, and banking inequalities in this country, exposing them to greater risk for water, land, and air pollution that may produce some of those underlying health conditions like respiratory conditions that lead Black Americans to be more vulnerable to COVID infection. For Latinx communities, in addition to the workplace vulnerabilities that I mentioned previously, Latinx people in the U.S. are engaging in experiencing a climate of fear, anti-immigrant hostility that makes them reluctant to come forward when they need health services. They're also disproportionately on or underinsured and maybe not eligible to receive federal stimulus benefits because they have undocumented status, so that the Federal CARES Act, for instance, that extended unemployment insurance to many laid off or unemployed or furloughed Americans, those benefits were not available to hundreds of thousands of people across the country who are undocumented. So newcomer communities in newer gateway states like the state of Oregon also have fewer social supports, and they face similar overcrowded housing conditions as agricultural workers that I mentioned for Black Americans, making it very difficult to shelter in place and social distance at home. For Native American communities, some of the other contributing social and historical factors leading to disproportionate coronavirus infection include structural conditions of land loss, dispossession, food and water insecurity, and chronic underfunding of the Indian Health Service. So for Native American communities, what's also been interesting to follow have been the ways that tribal governments have responded to the coronavirus infection in states like South Dakota, where the state level response has been very weak, producing their own systems for quarantining, for isolating cases, and for case tracking within tribal communities in order to contain the spread of the coronavirus. That's been some ways that communities have been responding in Native America that have been quite innovative and exciting to think about. So I just wanted to offer you one way to think as a social scientist. One way that I like to think about racial disparities in health is using the work of public health researcher Arlene Geronimus, who's at the University of Michigan School of Public Health, and she talks about underlying health disparities among African Americans now, not just for coronavirus infection, but across many other disease conditions such as heart disease, such as maternal mortality, such as life expectancy. And Geronimus has explained the disproportionate impact of health risk on Black Americans in terms of what she calls the weathering hypothesis. And the weathering hypothesis is basically a way to think about how the toll of racialized discrimination literally is embodied, or to use Geronimus's words, gets under the skin to impact the body's multiple physiological systems, resulting in health disparities for Black Americans. So weathering is a way to think about racism literally taking a toll on Black American bodies. And so I think this is a helpful framework to think about why Black Americans may be facing such disparate impact of the coronavirus. It's the social experience of racism that literally wears and tears on Black bodies through mechanisms like allostatic load or stress, and the coping with chronic stress of racialized discrimination that Black Americans must endure living in racist society, that makes them less able to confront coronavirus infection. In addition to some of those social structural factors that I talked about earlier, I think the weathering hypothesis is a useful explanation to pursue for thinking about racial and ethnic disparities in coronavirus and in COVID. So back to thinking about underlying conditions and thinking about multiple levels of influence on health. For me, as a professor of global public health, it's really important to teach what we call upstream social, historical, structural factors, things like housing inequalities, occupational risk factors, policy inequities, the chronic underfunding of public health system that leads communities of color in the U.S. to be disproportionately impacted during this pandemic. Why is it important for me to teach about these things? Because when we can analytically identify social conditions, structural conditions, and policies that produce health disparities, each of those things becomes an opportunity for us to target interventions, advocacy, and policy change. That is to say, I like to always leave my students with a sense that there is something to be done to remedy, rectify, and ameliorate health disparities. This isn't a condition of society that we just throw our hands up and say, there's nothing to be done. Similarly, it's really important to avoid what we call in public health victim blaming. That is, blaming the disproportionate impact of coronavirus, COVID-19, or any health condition that we might see the toll taking on certain population subgroups, to avoid blaming individual behaviors, and instead to think about the upstream social and structural conditions that are producing risk, that are leading individuals less likely to be able to ameliorate that risk or take those social distancing precautions. So in this way of avoiding victim blaming, avoiding blaming individuals, I'm thinking of the work of others that are sort of taking a stand in this way, asking for us to think about much broader upstream interventions. And I put a quote on the slide from Dr. Mary Bassett, who's at the Center for Health and Human Rights of Harvard University, saying that the focus on underlying chronic health conditions of Black Americans has directed attention away, unfortunately, from some of the social and structural conditions and inequalities that, for instance, make Black Americans less able to social distance, that keep them going to work even when doing so disproportionately exposes them to risk for coronavirus infection. So I liked that quote on the slide. I won't read it for you, but you can see it there. So I wanted to end with thinking about some policy responses. So if we have a multi-level analysis of health disparities, if we think upstream, if we think through a social and ecological framework about health disparities, not just for coronavirus, but for all health disparities in the United States, where does that leave us? So I think it leaves us with thinking about how we might, as Americans, come out of the current pandemic, not just with the way that we had public health before, chronically underfunded, certain Americans and communities of color disproportionately bearing the burden of workplace risks, but rather building back better through a set of social and policy and public health responses that can ameliorate risk and protect us against future health disasters and pandemics. So some ideas are just, floating out there, and I'm not inventing these ideas. Many public health advocates are talking about them right now, that we must robustly invest in a better public health system in the United States. As I mentioned earlier, the CDC's budget has been cut over decades, multiple presidential administrations, and this is something that we have to work against and fund the CDC if we want to have a robust laboratory and testing infrastructure ready for the next pandemic. It's just time to pass paid sick leave at the national level. The U.S. is one of the only wealthy country in the world that doesn't have paid sick leave, and we should have paid sick leave. That would keep people from going to work when they're symptomatic and keep the spread of disease, whether it's from flu or coronavirus or the next infectious disease epidemic that we face. We also must have much more robust workplace protections, occupational health and safety, particularly for frontline workers, people in agricultural, logistics, and healthcare industries. They should not be putting their lives at risk to go to work. And then finally, or two more comments, something that I've involved in the state of Oregon is robustly protecting undocumented Oregonians. There's an estimated tens of thousands of undocumented Oregonians, and they have been left out of the federal unemployment relief, the Federal CARES and Stimulus Act. So Oregon has an innovative policy proposal to help undocumented Oregonians who have been disproportionately impacted by the coronavirus pandemic and the economic fallout of the pandemic, with getting a one-time payment to help them pay bills, help them pay their rent so they don't lose their housing during this time. And there's quite a lot of national advocacy going on right now so that the next federal stimulus act includes undocumented Americans who are on the front lines and who should be protected and who should receive wage support through those federal bills. And then finally, I think that Science alone won't get us out of this pandemic. A vaccine alone won't resolve the problems that we're facing. We, as Americans, really must come together in a sense of shared and collective solidarity and build trust in public health, build trust in science, build trust in strong government leadership so that we can better confront this pandemic, find our way out of it, and better confront the next pandemic that we might face. So I just wanted to end with sharing my contact information there for the Global Health Program. As I mentioned at the outset of the talk, I direct the Global Health Minor. There is one core class for the Global Health Minor. It's INTL, or now it's GLBL, Global Studies 340, Global Health and Development. Quick plug for the class. I'll teach it fall this year, fall 2020, online. You are all welcome. There's no prerequisites, and we go into much more depth on racial and ethnic inequalities in health. So I look forward to having you in some of my classes and look forward to your questions right now.
Thank you so much, and we do have time for questions. We have several from the Zoom chat, and I want to make sure that we get to them. Sophie wants to know, how can UO students get involved in the cause of dismantling deeply rooted racial disparity during this pandemic? And how can our generation ensure that our nation builds back better to make a better future for us and others?
Thank you. That's such a great question, Sophie. Yeah, a slide I had to skip over because of time. The American Public Health Association, which is the professional association of public health professionals in the United States, has, declared racism a public health issue and has been working with city and county and state governments and health authorities across the country to think about ways to rectify health disparities, racial and ethnic disparities in health at local levels across the country. So it's really exciting to see that city governments, county health departments are now doing these kinds of racial and ethnic analyses of health disparities in their jurisdictions and designing programs, everything from through parks and rec departments to housing departments and housing access and housing equity to educational access and equity. All of these things will help us ameliorate disparities in health. So to Sophie's point, for students, what we try to do here on campus through the Global Health Program, we require a field experience or internship, and it's super exciting for me to be able to mentor students who are interning at the Lane County Department of Public Health, at Beyond Toxis, we're working on issues of environmental justice, with migrant and refugee rights organizations here in the state of Oregon, getting hands-on skills so that they can go out and be the next generation of public health leaders addressing these problems moving forward. So I think those are my best responses to Sophie, but those are a great set of questions.
Wow. There's some really great ones in here. Okay, so you kind of talked a little bit about this. Health disparities for some groups, such as Black Americans, are not isolated to the increased infection and death rates that we're seeing now. What ongoing disparities do people of color experience in the U.S.? You mentioned maternal mortality and heart disease. Are there other things, and what other kind of institutional factors play into that? It's not just that the health system needs to be changed. It feels like there's other factors at play in these disparities.
That's right. So thank you for that question. So the resource slide on my presentation, if students have access to it, there's a link there to a Twitter account by New York Times reporter Nicole Hannah-Jones, and she did an amazing series on COVID-19 disparities among Black Americans, and she put it out on Twitter. She basically curated a set of news pieces and published it mid-April, looking at all of these underlying factors. So, things like historical redlining and racial segregation that leads African Americans to having the lowest rates of home ownership in the country. So how might that be shaping vulnerability to infectious disease, disproportionate infection rates during the pandemic, precisely because if Black Americans are less likely to own their own homes, they're more likely to live in multifamily dwellings where overcrowding conditions are common and where it's much harder to social distance. So that means one member of a household has coronavirus, or test positive for coronavirus, much harder to isolate that person in overcrowded housing conditions. Just one example. Also, residential segregation segregation leads to things like less opportunities for recreation or open space or just safe neighborhoods, leading communities of color, Black Americans, less able to go outside and recreate. So where many of us in our neighborhoods can go for walks and play in parks, even during stay-at-home orders, people who are living in communities that are residentially segregated may not have those opportunities. And that, of course, can contribute to stress, to anxiety, the inability to physically be able to engage in physical activity during the pandemic has contributed to some of those mental health effects that I talked about earlier. So it's really complicated. One thing that researchers like to talk about is just the compound effects of racial discrimination through that weathering hypothesis that I mentioned on stress overall. And so the way researchers measure this is looking at something called allostatic load, where they take things like cortisol, blood pressure, height, weight, put a bunch of measures together and create this composite measure of allostatic load. It's essentially a pinpoint to be able to look at stress and the toll stress is taking on the body, how the body's sort of fight or flight mechanism is always keyed up. And consistently across multiple studies, we find that Black Americans and Brown Americans have much higher rates of chronic stress. And that just weathers, that takes a toll on the body. So leading to things like heart disease, leading to things like maybe even cancers and other chronic conditions. So we see these racial disparities in health in a number of conditions: infectious disease, chronic disease, maternal mortality, and most abruptly or just sort of graphically or visibly, life expectancy. Black Americans have the shortest life expectancy in the United States, and then Native Americans. And so those are just clear things that we can say. There are health disparities that must be remedied, because when people are living less years of life, that's preventable death, as I said earlier. So this is why for public health communities, public health professionals, racism is indeed a public health issue, and we have to begin to craft policies to address those upstream social and structural factors. Hopefully that responds to the question.
Yes, absolutely. Thank you. Actually, the question for me, it sounds like your research interests actually can intersect quite well with lots of other kinds of research that's done not only on our campus but with others. Do you find that you interact with or rely on the research that's done by others on campus? I think of biologists or anthropologists. How do you work with others on campus who are in different fields? And would you welcome a student who is, say, a human physiology major but interested in this topic? Would you welcome them as a research student?
Yes, definitely. Thanks, Cora. Yeah. So the Global Health Minor Program has been around for 3 years. This will be our 4th year. And the minors in Global Health have majors across campus. So many are human physiology, biology, and chemistry. They're pre-medicine or pre-clinical students who want to add a public, cross-cultural, public health, population-based health perspective to their more natural life sciences major degree. And so, yes, I work all the time with pre-medical and preclinical students. I also have a little mission to get some of them interested in getting their own master's in public health, because I have a master's in public health. And I'm really proud of that degree and really grateful to be a part of the public health community, particularly at this time. But we also have students from the professional schools, journalism, planning, policy, and management. I also work with students in history and English and literature who are looking, for instance, at narrative representation of disease, health, and illness across different cultural groups or cross-nationally or historically. So I work with philosophy students who are interested in ethical questions related to health and illness, death and dying. So I love being a part of the Global Health Program because my colleagues from across campus represent all the fields you mentioned and more, and our students represent all those fields. So we draw on the tools of the social sciences, of the humanities, of the natural sciences to help us understand health problems and address them. And it's really, I think, an exciting field. I I can't, I'm just really proud to be a part of it. And I feel like the pandemic, unfortunately, the one positive thing is it just reminds us how important public health is. And so I think that, getting an undergraduate education that gives us some of these basic fundamental tools to understand principles of public health, flattening the curve. My students understand epidemiological curves, so I'm glad to be able to give them the skills to make sense of the problems that they will encounter in the world, so hopefully that responds to your question.
Yeah, and how does a student connect with you if they want to, as an undergraduate, get involved in the research and the work that you're doing? Do they email you? Do they just approach you after class?
The best thing is to take classes, get to know, I think this is speaking for myself, but for many faculty, take classes with faculty, engage with them in office hours. In the spring we had remote classes, but I had remote office hours 4 hours a week, and they were filled with students, and it was really fun. I do remote office hours over the summer. So talking to students about maybe doing independent research projects for their field experience or internships, or working on research projects with me or other faculty on campus as research assistants, getting research experience, and maybe having the opportunity to publish papers with professors. So I have a student, actually two, working with me this summer on a project I'm working with Lane County Department of Public Health. As I mentioned earlier, we're doing a survey at Latinx free testing sites for COVID-19 of where Spanish-speaking community members get their information about coronavirus and COVID-19 so that the health department can better design health communication and disease prevention strategies to the Spanish-speaking community in our county. And the students who got involved with me, it happened because they were in class with me in the spring. I knew they had Spanish-speaking ability, and I knew they were interested in Latinx health issues. So just having a relationship and explaining your interests with your faculty members and offering to get involved with their research projects, I think that's the best way. And many UO faculty, and particularly faculty in the Global Health Program, we love working with students. I have multiple co-authored journal articles with students, and I love doing that. I love mentoring students. It's one of the favorite things about my career here at the University of Oregon. So
nice. Thank you. It's also a great way for you to grow your profession, right?
Definitely.
Okay. Well, that's all the time that we have for this session. For those of you who are watching, thank you. Again, for students, be sure to log on to community.uoregon.edu to submit your reflections and to stay on track to complete introduction. If you've completed your flock meetings to date and the advising prep module on the community.uoregon.edu site, you should have been invited to schedule your academic advising appointment, which will open up class registration so that you can register for Dr. Yarris' class. That'll open up for you as soon as you're done with your academic advising. Make sure you're checking your @uoregon.edu email address for information from your advisor and make your appointment right away. For questions about introduction, this session, or any introduction-related question, you could also email us at orientation@uoregon.edu, visit our website, orientation.uoregon.edu, or text us at 541-346-1159. Thank you for your time today, and to you, Dr. Yarris, thank you for helping our new ducks get ready for fall.
Thank you.